I would like to invite our guest speaker, Dr. Mayank Nilay, to proceed with the second session. Dr. Mayank Nilay did his PhD in pediatrics and DM in medical genetics. He is currently working as Assistant Professor, Department of Medical Genetics, Postgraduate Institute of Child Health, Noida. He also worked as an Assistant Professor in Department of Medical Genetics, Lucknow, SGPGIMS. He acted as Senior Resident in MAMC and LNH, New Delhi. He also worked as an editorial board member at SVOA Pediatrics, London, UK. Dr. Nilay has published 15 national and international research publications. He has been actively involved in the management of children with muscular atrophy and genetic hematological disorders. For today's presentation, Dr. Nilay will be talking about breast cancer, perspectives from a clinical geneticist. Please, sir.
Good evening, everyone. Hope my slides are visible, Shefali.
Yes, your slides are visible.
Yeah, they're very clear and visible.
Okay. At the outset, I would like to thank Yoda Diagnostics for giving me this opportunity. And again, it's a privilege to share this session with Professor Dr. Raghunandan Rao, one of the stalwarts in the field of oncology, and Dr. Pavni, who is well known for her work in genetics. I won't take much of your time in the introduction, as most of the things have already been discussed by Sir. I'll concentrate more regarding the genetics part and the role of genetic testing in this era of NGS. As you all know, the common facts about breast cancer already told about Sir. So I'll move quickly with these slides. In India, it accounts for around 25 to 30% of all cancers in women. This slide, this data I've taken from WHO for the year 2018. You can see that the incidence of such cancer in women in India was around, breast cancer was around 28%. Similarly, in the mortality cases, the deaths, the reason for breast cancer was around 24%. So it's quite common, as already told by Sir. Again, the risk factors already discussed regarding menarche, menopause, estrogen exposure, obesity, and all those things. We'll quickly move on to the next slide. Again, the signs of breast cancer, which any girl, any woman should be careful. Like if any redness or rashes there, any discharge, any constant pain, any inverted nipple or change in the position, change in the skin texture, any lump, change in size or shape of the breast. These are certain trivial signs. I will start with a case. A consultant in genetics, you tell to that person who comes to the doctor regarding some issue in the family or for himself or herself. A lady of 24 years old female, she visited our OPD. She was an asymptomatic individual, but there was family history of breast cancer and ovarian cancer. And she was quite anxious. She wanted to know her own risk for developing the cancer. As from media and all internet, she was quite worried and she wanted to go for a genetic test. As for any case for such genetics related disorders, even in cancer genetics, a 3-generation pedigree is very important. So whenever such a female comes, or even when she's having a cancer or not, first we should go with the family history. With you a 3-generation pedigree, you can see this is the woman who consulted us. Her mother died with ovarian cancer at 46 years of age. She had a maternal aunt who was diagnosed with breast cancer at 45 years of age. Similarly, the sister of her maternal grandmother, she had also history of diagnosis of breast cancer at 45 years. We'll discuss at the end how we dealt with this case. In my next slide, I'll discuss a little bit about the oncogenetics. Basically, most of you know, pathologists and pediatricians and oncologists who are part of this session, that cancer is primarily a disease of abnormal gene function. Any mutation occurring in the gene, it may lead to cancer. Any mutation which is affecting the cell cycle, which is leading to increased proliferation of the cell, and abnormal proliferation, increase in the number and size, may lead to cancer. 2 types of mutations are known. Either they can be acquired, which are the somatic variations, or it can be inherited, which is the germline variation present in the germ cells. Somatic variation is not present at birth, but is acquired over the lifespan in an organ. Famous saying from National Cancer Institute, all cancer is genetic, in that it is triggered by altered genes. Genes that control the orderly replication of cells become damaged, allowing the cells to reproduce without restraint. Most of these cancer-causing genes are either associated with proto-oncogenes or tumor suppressor genes. I'll discuss in brief about the hereditary cancer syndromes. As you all know, October is also the Cancer Awareness Month. And being a geneticist, we need to discuss a little bit more about this syndrome. Basically, such cancer syndromes, they have a genetic predisposition to certain tumors, and generally they have an early age of presentation, and mostly involvement of germline mutations is there. But again, same gene which is causing a germline mutation or hereditary cancer syndrome, it may cause a sporadic cancer as well. Sporadic cancer means like a cancer in a single individual in which no family history and all are there. Around 5 to 10% of all the malignancies are a part of hereditary cancer syndrome. This is very important to know because most of the times people are confused, like, okay, cancer is there, it is like genetics. It's not 100% hereditary. Around 5 to 10% are only hereditary. Even for breast cancer or HNPCC or other hereditary cancers. Basically, germline mutation is present in every cell of the body, and where it occurred de novo for the first time in the germ cell of the parents, egg or sperm, and it was inherited from a parent. Most of these hereditary cancer syndromes, they have an autosomal dominant mode of inheritance. This we need to know because this is required during our counseling session to predict the risk of recurrence in future siblings of the woman who is coming to us, or like for other, even for her progeny. As you can see, this woman is having a mutation, she is a carrier, suppose for BRCA1, is having a pathogenic variant, she is a known case of breast cancer. You can see from this slide, there is every pregnancy, there is a 50% chance of transmitting this pathogenic variant to her progeny. This is the common thing about autosomal dominant inheritance. Now, certain common hereditary cancer syndromes, apart from hereditary breast and ovarian cancer, we have HNPCC, Li-Fraumeni syndrome, and multiple endocrine neoplasia. We will concentrate more on the breast and ovarian cancer. There are certain typical characters of these syndromes. Incomplete penetrance and phenocopies are seen. Now, what is incomplete penetrance? You should know that penetrance is like, for example, if we take in a layman language, it is like the chance of manifesting all the features of the disease if one is harboring the same pathogenic variant as a known variant or a variant present in one of the affected members of the family. So this is quite common with these syndromes. Even for a BRCA1 and BRCA2, 100% penetrance is not there. It might occur that the mother is a known case of breast cancer, she is harboring a variant, same variant is present in her daughter, and she may or may not manifest the disease in her lifetime, or the age of presentation may vary. So such things are quite important in dealing with such families. Already told, most of them are tumor suppressor gene defects. Tissue specificity is common. Most of these syndromes, like specific tumors, are present, and genetic heterogeneity is known. As was asked in the question chat box as well, what about BRCA1 and BRCA2 negative? Lot of other genes are known which are causing sporadic breast cancers as well as the familial ones. Certain other things which we should keep in mind for whenever to suspect a hereditary inherited cancer. Several first or second degree relatives with a common cancer will be there. So a detailed family history is important. Several close relatives with related cancers like breast and ovarian cancer, or two family members with the same rare cancer, and unusually early age of onset, bilateral and multifocal tumors. Most of these familial cancers are bilateral, multifocal, while the sporadic ones are generally unilateral. And again, tumors in two different systems in the same individual. Even a patient may come, he may have a sarcoma, he may have a breast cancer, other things can be there, even colon cancer can be there. Again, certain other features which is very important, that is head-to-toe examination. For example, mucosal hyperpigmentation as seen in Creutzfeldt-Jaeger syndrome, capillate spots can be seen in NF2. So even such features are, certain extra features are there, we should think about such familial cancers. Okay, regarding hereditary breast and cancer, and when you search this breast cancer word terminology in OMIM, you can find around 22 to 23 genes mentioned. Okay, and also already told by sir, most of these are sporadic, only 5 to 10% are familial, and most of these genes you can see, apart from BRCA1 and BRCA2, lot of other genes are as well in this list. And in those familial breast cancer patients, in various studies published, still around 40 to 50% of familial cancers, we are not able to find any susceptible gene to which we can relate the disease. And again, you can see I have written somewhere low susceptibility genes, somewhere it is high susceptibility genes. What does that mean? It means that mutation in these genes like BRCA1 and BRCA2, which is only about 25% of the familial, or like the murder susceptibility genes, these are the Fanconi anemia pathway genes. These are high susceptible, which means that the chance of getting a cancer is more when variation is present in these genes. Similarly, there are certain low susceptibility genes, around 70 genes have been identified, in which the chance of having that breast cancer is quite less. In this slide on y-axis, we have shown the relative risk of developing the cancer, and x-axis is the frequency in population. You can see these genetic variations in like TOX3, FGFR2, certain chromosomal microdeletions, duplications. These are quite common, like polymorphism. These variations present in these genes are quite common in the general population. But again, in various studies, it was shown, basically genome-wide association studies, that they have an increased risk of predisposition to breast cancer as compared to general population. While again, TP53, PTEN, BRCA1, CDH1, STK11, these have a high penetrance. Now, coming up to BRCA1 and BRCA2, it is the most frequently identified monogenic cause for hereditary breast and ovarian cancer. Around 30% of hereditary breast cancers have this gene defect in BRCA1 or BRCA2. But again, 2% of all the breast cancers, if you take on the complete scale, and the overall prevalence of this mutation can be 1 in 400 to 1 in 800. And again, as told by sir, in certain ethnicities and populations, very high prevalence has also been seen. Regarding the molecular genetics, both these are tumor suppression genes. They are basically involved in DNA mismatch repair. As most of the other cancer-associated genes, basically these are associated with the cell cycle checkpoints. And again, the DNA damage repair and all. So again, if a mutation will be there, that repair will be affected, which will lead to cancer. Most mutations in these genes are frame shift mutations, loss of function. 10% cases, we can have rearrangements as well. Again, there is a concept of founder mutations, as told by sir as well in certain Scandinavian populations, Ashkenazi Jews. Certain pathogenic variations are quite common. So such mutations are known to be founder mutations. Autosomal dominant inheritance already discussed. One important thing is regarding the ovarian cancer cluster region. This is a region present on the exon 11 in BRCA1 and BRCA2, and it was seen whenever the mutations are present in this region, apart from breast cancer, the chances of ovarian cancer also increases. So this is also very important where you are dealing with such patients. When you have a report, you can better counsel them regarding the prognosis and the increased occurrence of ovarian cancer. There are websites on which updated mutations are there. Every day they are being updated. Again, cancer risk for carriers, discussed many times in many webinars and everywhere, that again, if one is carrying a BRCA1 and BRCA2 mutation, you can see the risk of breast cancer up to the age of 50 is around 51%, which is quite high as compared to general population. Even at the age of 70, this may increase up to 87%. Similarly, for male breast cancer, if one is having a carrier of pathogenic variation, again, a 7% risk of male breast cancer is there. Similarly, BRCA2 is also associated with certain other cancers like prostate, pancreatic, and melanoma. So such incidence in the family is also very important. And if any such affected males are there, in which a female is having a breast cancer and a BRCA2 mutation, and the male is harboring this mutation, then we should keep them on screening for prostate and as well as a high index for pancreatic cancer. Again, same thing is being shown here. You can see the risk for male breast cancer, it increases to 9%, more associated with more aggressive course with BRCA2. Similarly, about prostate and pancreas. Now, typical characteristics of BRCA1 and BRCA2 positive cancers, as told by sir, most of these are triple negative breast cancer phenotype. So any breast cancer patient, if we have a triple negative phenotype, we should think about BRCA1 and BRCA2 screening. They have a distinct histopathology. They have a high mitotic index, Cushing margins, and lymphocytic infiltration. And also they are highly sensitive to platinum salts. And higher prevalence of serous adenocarcinoma of ovary has also been associated with BRCA1 and BRCA2. Every now and then guidelines come from the National Comprehensive Cancer Network from the US, in which they give various guidelines like to when to go for screening in a family. This can be a bit cumbersome slide. I have simplified it to others. Like if an individual is from a family with a known deleterious BRCA1 and BRCA2 mutation and having the features of breast cancer, then we should go for genetic testing. If personal history of male breast cancer is there in any male individual, personal history of ovarian carcinoma, personal history of metastatic prostate cancer, and again, if BRCA1 and BRCA are detected by tumor profiling, the somatic mutations, if a personal history of pancreatic cancer is there, and also if they are from Ashkenazi Jews population. Similarly, if a personal, to elaborate it more, if a personal history of breast cancer along with one or more of the following, if the family is having an individual who was diagnosed at an early age, less than 45, or diagnosed between 45 to 60 with an additional breast cancer primary. Also, if more than one close relative with breast cancer at any age, or more than one close relative with high-grade prostate cancer, or any case diagnosed less than 60 years with triple negative breast cancer, we should give them an option for genetic testing. Further clarification in the options, if the diagnosis is done at any age, but again, if one relative is having breast cancer less than 50 years, or there is a male breast cancer history, or there is a history of pancreatic cancer, or a metastatic prostate cancer, or additional history of ovarian cancer, we should give an option for genetic testing. Certain in this era of NGS, many times people are coming with no family history and they are quite anxious for getting a genetic test. We should be quite aware and be cautious for this direct to consumer testing. Anyway, if you are planning for a genetic test, always consult an expert, a geneticist or a genetic counselor. If you have no personal history, but again, if any of your first degree or second degree relative are meeting any of the above criteria, you can go for a genetic testing after proper consultation. What are the benefits of a genetic testing? That also is required because it can even help in treatment. As already told by sir, there are PARP inhibitors like olaparib, which are quite effective in BRCA-linked ovarian cancer. Then again, certain individualized therapies, like if one is having a TP53, most of the sporadic cancers may have a TP53 mutation, the radiotherapy can be avoided. And again, the chance of detecting a secondary cancer, that also depends on the specific gene mutation found. And again, for the relative of the patient, we can go for a cascade screening or extended family screening. And if one is found positive, we can put them on surveillance and surgery can also be done. Reassurance if mutation is absent, but again, it cannot give a 100% guarantee because as told earlier as well, many new genes are coming every now and then. And again, some families may also opt for a prenatal testing or a pre-implantation genetic diagnosis. But again, there may be pros and cons. Some may support because it is not that a highly mortality disease, like the child may not die at an early age, like some may not even 100% penetrance is also not there. But again, depending on the choice of the family and the extent of the mutation, we can discuss the option of prenatal testing as well. So any genetic testing while proceeding, suspected hereditary cancer, a pre-test genetic counseling is quite important. Will be discussed in detail in the next session. And again, after the report comes, the implications of the report is also important. That becomes a part of the post-test genetic counseling. Now, little bit I will tell about the next generation sequencing, because most of these patients who are going for this cancer testing are going for a genetic test based on the next generation sequencing. Either they can be a multi-gene panel involving all the cancer causing genes, or it can be a clinical exome for the common disease causing genes. So we should know what is an NGS, the basic principle. In this, all the DNA which is extracted from the peripheral lymphocytes, we go for a parallel sequencing, in which means the DNA is fragmented into a library of small segments that are each sequenced parallelly at the same time. And then they are aligned. Individual sequences are reassembled by aligning to a reference genome. And further, they are sequenced. The whole genome sequence is derived from the consensus of aligned reads. It cannot, it is looking quite simple, but it's not that simple. A lot of work is required, like library preparation, wet lab work, and a lot of bioinformatics is involved. And then genotype phenotype matching is also very important. Many times the doctors may send the genetic test to a lab. They may just write the family is having a cancer. No, that won't help, because if you not give a complete clinical feature to the lab, they won't be able to do that genotype phenotype matching. So detailed clinical history, clinical examination findings, all this is very important for a better diagnostic yield of such next generation based tests. Already told, positive result is there about breast cancer. We should initially go for BRCA1 and BRCA2 if you are suspecting familial, because they are the most common ones. If a negative result is there, okay, we can keep then a routine breast screening as it is for general population. If positive result is there, we can go for preventive strategies. And again, sometimes in such genetic testing, we can get variants of uncertain significance. This becomes quite troublesome, because in future, some of these may become benign or some may become likely pathogenic. So as a lab or as a clinician dealing with such patients, we should always do a re-evaluation after 6 months or 9 months of all those cases which are coming variants of uncertain significance. Also, certain additional investigations like functional studies, tumor biopsy specimen, and all other things, corroborative findings, can add to the variant becoming VU as to likely pathogenic. So all that assessment is not that easy. That's why a consultation with a geneticist is important. Again, negative result, unidentified familial mutation can be there. And again, the management plan depends on the family. So the benefits of genetic testing is that it identifies high risk individuals, it identifies non-carriers, allows early detection, and may relieve the anxiety. But again, certain limitations are there. It cannot detect all the mutations. As you saw in previous slides, a lot of other genes are also there. And the problem of incomplete penetrance and variable age of onset is very important during counseling. Again, certain risk assessment tools are there which are online available to predict the risk of a breast cancer and going for genetic testing. You all can check these sites like IBIS risk assessment tool is there, which basically take the age of onset and other features in the family. Certain other like board ICA web application is also there, in which you can put the findings of the patient, and it also shows whether the risk for the occurrence of breast cancer is there or not. There can be many other web applications, standard ones. Management, again, surveillance, self breast examination, ideally should start at 18 to 20 years. Various bodies have given various recommendations. Breast MRI mammogram already discussed by sir. Primary prevention is like prophylactic mastectomy, such, but again, certain ethical issues are also there. Many people may not like those radical procedures, but again, it is up to the choice of the patient. Risk reducing salpingo-oophorectomy, chemoprophylaxis can also be tried. As you can see in this slide, the cancer risk reduces with these proven medical management. As you can see, oral contraceptives, they can decrease the risk of this ovarian cancer up to around 60%. Bilateral salpingo-oophorectomy can also decrease the risk of ovarian up to 96%. Similarly, for breast cancer, tamoxifen, prophylactic mastectomy and all can reduce the risk. Similar is for colonoscopy and all for colon cancer. BRCA1 positive women, breast self-examination beginning at age 35, annual clinical breast examination, and annual prostate cancer screening is also important. So for genetic evaluation of family, we should take the family history to decide who are the relatives at risk. Pre-symptomatic testing shouldn't be given below 18 years of age. This is also very important, because after that age, the patient achieves the right age to give consent for the testing. Of course, prenatal testing can be offered after explaining the incomplete penetrance. Now back to the case which we had discussed. As you can see, after all these discussions, she had a first degree relative who died at age of 46 with ovarian cancer. She had also a second degree relative with a breast cancer diagnosed at 45 years of age. So in this case, again, we didn't go for testing of the consultant. We asked her to get the testing of the proband. So it is always the dictum to genetically test the person having the disease. Okay, so this maternal aunt was tested and she was found to have a mutation. She was found to harbor a mutation in BRCA2 gene, which was a known pathogenic variation. And then I think the audience will agree, as this lady was having a risk for breast cancer because of this typical positive family history, we gave her the option of targeted testing as well. Again, at the end, I would like to recapitulate all the points. Breast cancer prevention tips already told by sir. Need of the hour is early detection, screening mammography after 40 years, awareness on self-examination, and again self-examination, which will be discussed further. And again, certain myths and facts about this disease is there. A lump in your breast means you have a breast cancer, but the fact is only a small percentage of lumps in our cancers. Most of them are benign. If a family history of breast cancer, then you will develop breast cancer too. It's not necessary, because only 10% have a family history of the disease. Breast cancer is contagious. No, it is a non-communicable disease. And again, certain myth is that mammogram can cause a spread of breast cancer. This is also false. In fact, it's help in the early screening. At the end, a multidisciplinary approach is important, including all the doctors, whether it is a cancer specialist, geneticist, or the surgeon. So I'll end my session here with a quote like gender equality today for a sustainable tomorrow. Thank you.
Thank you very much, sir, for the great talk. I've got one question from the attendees. So, sir, is it possible to reduce breast cancer risk by influencing epigenetic factors such as methylation or histone acetylation?
Yes, yes. Methylation is reported in most of the cancer, even for certain breast cancers, in which the sequence will be the same, but epigenetic influence like methylation may cause the cancer. So certain studies can be there on the somatic, the tissue specimens. Methylation is known to influence cancer.
Okay, okay, sir. So we also have another question. Like, do you think consanguinity affects breast cancer incidence in a family? So you're mute, sir.
Consanguinity you are asking? Now,
Yes.
as already told with discussed with you all, most of these hereditary cancers have an autosomal dominant mode of inheritance. So there is no specific risk for consanguinity. Like most of the autosomal recessive disorders in which the parents are carrier, consanguinity becomes quite important. But for as such cancers, no specific risk for consanguinity is like other normal general population.
Okay. Okay, sir. Thank you very much, sir, for providing us with much needed information about the role of genetics in breast cancer.